we'd like to welcome Chuck Jaffe.
Good morning, good afternoon, and good evening around the world. It's a real pleasure to be here and welcome you to the second day of HL7 FHIR DevDays. I think everyone can agree it was a remarkable achievement yesterday. Much of it is due to the remarkable efforts of hundreds of FHIR developers, students, and the broad community around the world that participated in the event. I think all of us learned something from it. I did want to thank again the sponsors without whom this would not be possible, including Microsoft, who helped support this program years on end. In addition, I want to give special thanks to the Ewout Kramer and the FHIR team, to Wayne Kubik and the HL7 staff who developed this program, hours and hours of their time. Lastly, I'd like to reminisce a little bit about a passion I had when I played lacrosse in college. It wasn't so much the ebb and flow of the game, although that was magnificent when played well. I think for me, the most gratifying part was the teamwork. It made 10 individuals seem like a finely honed instrument. Today, I don't like to get bumped into. I'm slow to get off the ground. And instead, I teach a class called the Futures of Science. It's a colloquium. Participants of all ages support ideas about the future of science. We talk about everything from chemistry to immunology, clinical genomics, to biophysics. One of the discussions that always arises is the science of microeconomics. Inevitably, someone asks, if you're looking into the future, what is the best investment? I can't help but saying the best investment is in people. And HL7 FHIR DevDays exemplifies that at its very best. So congratulations to all of you. Look forward to 3 more days of excitement. And I'd like to turn it over to my colleague, Ewout, for introductions for today. Thanks to all of you.
Thank you, Chuck. Yes, back from the west coast of the US to Europe, Amsterdam. Welcome to DevDays again. Welcome to those new today. I know there's quite a few of you who have joined only today. So I will go over a few of the points that have been going over yesterday. But first, as I promised yesterday, I'm going to try to make it a little bit less virtual by showing you around my house. Yesterday, you saw me on the bicycle. Today, it's my kitchen. After all, it's 5 minutes past 7 in the evening here in Amsterdam. Dinner time. So I must admit, my kitchen normally doesn't look as neat as this. I prepared this especially for you. It's a very good excuse to clean up your house now and then. Also, the other parts I'll show you tomorrow and the day after tomorrow. So it's going to be simple today. After this, I'll be finishing off grilling the peaches here. And I already prepared the salad there with rucola, prosciutto, goat cheese. And I cooked my own balsamic syrup here. So I'm going to throw everything together after this, grill the peaches and enjoy. And then after that, I'll be joining the sessions again here from Amsterdam. So that's my kitchen. I'll think about what I'm going to show you tomorrow. Next, we'll go over the presentation, share. Yep, there we go. So welcome to DevDays. Again, my name is Ewout Kramer. I am CTO for FHIR. The guys with the yellow shirts here, normally we're everywhere on conference helping you out, but now we do it from our own homes. Just as a reminder that it's the second day of DevDays, and normally that would have meant that today was the day of the social event, which looks normally like this. So we get in the bus with everyone, and then this is in Amsterdam, one of the Amsterdam editions. If you look very well, you can spot Wayne here. And this is back when we still fitted in a single pub. We don't anymore. So we're trying again tonight with a virtual pub crawl, but more about that later on. Then the tracks for today. Well, we had already the opening. It's basically the same as yesterday. The first 50 minutes, you don't have to have any kind of fear of missing out because there's a single track, and that's the Zoom channel that you are on now. So I'm doing the opening now, and after me, I will hand over to Matthew Holt, who will do the 20-minute keynote. And after Matthew, we'll see again the patient innovator track being introduced by Dave de Bronkert. And this time, of course, there is another pitcher, and it's Olivier. I had the pleasure of speaking to him already just before we started off here. And he will pitch for the Patient Innovator Award. And that would close the session. I think we'll end up a little bit early, but who knows? So there's a little bit of time, and then at 2 p.m. Eastern, that's 8 o'clock Amsterdam time. We'll split up like we did yesterday, which means that you'll have to choose. So again, basically the same 40-minute blocks for each session, and there will be 4 to 5 sessions at the same time. Exception again is the community track. These are 15-minute talks. And these talks are done by people who have actually implemented FHIR in their country, in their company, and they want to tell you about that. And that's from 3:30 onwards. You'll see quite a few tracks called Let's Build now. These are practical work tracks, and most of the time these are continuations of tracks that started yesterday. So they had a tutorial yesterday and started doing some practical work, which today probably will be discussed and looked upon. If you haven't followed the initial tutorial, you're of course welcome to join, though you might have missed a little bit of the background. What's not on this slide, but it is in your program, is the virtual version of our yoga. Normally we have massages and everything for you to stay totally in shape, but today you have to do it yourself. However, we do have chair yoga somewhere in the middle of the program. So I encourage you to join. If you don't do that, do like me, just run up the stairs a few times, up and down in your home to keep fit and moving. We'll be sitting for another 3 days after all. Okay, next. So as I promised you, the day will end again, actually, like yesterday. Wayne will give us an overview of what happened today, but he will also introduce the pub crawl. I'm not gonna say a lot about that because I'm sure Wayne is gonna do that, but there are 5 pubs across the world that participate, and they are simply in your agenda. And there is a Zoom link there, so it's not in Wova. There's a Zoom link there that you can click and join. Don't try it now, it's closed, it's way too early where you are, and although it's 7 o'clock here, we'll just wait a little bit before we open up these pubs, so there will be no one there. There is an advantage, however, of these virtual pubs, and you can actually visit more than one and be drunk in more than one. That's something you can't normally do at the same time, so another advantage of being virtual here. Again, during the sessions, use the Wova Q&A. We have moderators, as some of you have seen, but those new here, I'll show the picture here. This is the web app. There is also a mobile app. And as we've seen yesterday, when there are technical difficulties, sometimes the mobile app works and the web does not, or vice versa. But I'm asking you to post your questions there at that session Q&A, not in the chat, which is the next tab. And I think it's still true that if you want to refresh and make sure that you see the latest questions, you can switch between the chat tab and the sessions Q&A. It doesn't work perfectly yet, but in any case, don't use the Zoom chat. We're not monitoring that one. And we had, for about 10 to 15 minutes yesterday, some connection failures in the sense that if you wanted to switch from one session to the others, I encourage you to do that yesterday. I said there's no social impediment here being virtual to switch from one session to the other if you think something somewhere else is more interesting. But we had a point where you couldn't get into a new session anymore, and also were not able to go back to your old session. Whova was aware of that, and it should be fixed. If not, we'll provide the direct Zoom links for these meetings in the agenda. So if you're being kicked out again and you can't get back in, just click on the direct Zoom link that will appear in the agenda. So I hope, well, we're going to see. We're all software developers, so we know how this goes. We reported a bug, they're aware, they've tried to fix it, they've probably worked the whole night. We'll see whether they were successful. We're a bit of testers today. Yesterday's recordings, I didn't do that, but if you scroll back to yesterday's agenda, there will now be a button say watch recording, and you can actually see most or all of the talks from yesterday. They're all at your disposal whenever you want. There's still a lot to see today, but if you feel bored, you can already scroll back and see what happened yesterday. No, I want to go this way. There is a whole team behind this. You just see my yellow shirt, but there are actually quite a few yellow shirts sitting around the world. And looking for that channel there in the app or in the desktop, ask the organizers anything. They're monitoring the Q&A, they're monitoring Zulip, they're monitoring this channel. So if you have any problems or questions, post your questions there, and I'm pretty sure your question will be picked up pretty quickly. As usual here, I'd like to thank our event sponsors, without whom certainly in these times, doing an event like this would not have been possible. So thank you for that. And of course, this event is brought to you by HL7 and FHIR, and our host sponsor is Microsoft. Good. Now we're actually ready to really get going, and the first speaker is Matthew Holt. Matthew is mostly known for his healthcare blog, and of course also because of the Health 2.0 conferences that he helped start up. And nowadays he's got another company called Smack Health, and I went there because I hadn't heard about it. And well, I must say his website applies the best practices. I looked at the first page and I immediately understood what this company was doing. So kudos for that, Matthew. That's not always the case. So without further ado, Matthew, I know you're going to talk to us about what COVID-19 means for the continuous hospital. And I'll just pass the mic to you.
Oh, thank you so much. All right, well, that's absolutely true. Good morning, afternoon, evening, wherever you guys are in the world. I am talking to you from Northern California. It's nice and sunny here. Occasionally I'm hearing sirens go by, which probably means that there's a fire. So hopefully not coming down the path towards me. You will hear screaming and yelling and dogs in the background because like many of you, I have young kids at home. Oh my God, and I've of course forgotten to get rid of my phone. So the one thing you shouldn't do as a professional presenter is not to unmute your phone. I failed on that one. All right, so apologies with that. So I'm going to talk to you today about the concept of what is going to be the end result, I hope will be the end result of COVID-19. So I'm not going to talk too much about the COVID-19 impact, I'm going to talk very little about FHIR. It's pretty clear that I am, of all the sort of 300 or 400 people on the line, I'm the one who knows the least about FHIR and the deep technology, and you'll hear a lot of smarter people than me talk about that. What I am going to talk to you about is what I think is going to be the end result of FHIR. So if you want to find me, there's all my details. I'll show them again at the end. But now I'm just going to go off and talk to you a bit about what's been happening overall, mostly in the US healthcare system, but this does reflect broadly across the world, and how I think we need to think about changes. I'm going to actually lay out some details about what that structure is going to be. All right. So, doesn't take a genius to figure out we have been through a hell of a lot. And there's a lot of different things going on at the same time. So because of the US, nature of the US system, you look at the bottom left here, we have a lot of Americans who lost health insurance, a lot of concern about health insurance. And both hospitals and primary care doctors are struggling to survive. We have seen a big surge in the use of telehealth and virtual care. But in general, these are testing times for the healthcare system. You may not know this, but the collapse in GDP in Q1, about half of it was a collapse in revenue of the healthcare system. A lot of back and forth about how bad this really is going to be for hospitals and primary care practices, but clearly it's a big disruption of the system. What it indicates is that we've been paying healthcare organizations in the US in basically the wrong way. And we need to start figuring out how to do a better job of that. We've been paying them to do elective procedures, surgeries, and on a fee-for-service basis for visits. And that's how it's been for basically the entire history of the US. That needs to change. The good news is, well, I'll let Steve Austin tell you. So you remember this.
Steve Austin, astronaut, a man barely alive. Gentlemen, we can rebuild him. We have the technology. We have the capability to make the world's first bionic man.
All right. Do you anybody remembers that from the 70s? One of my favorites. Actually, you can look it up on YouTube. There's like a whole minute-and-a-half introduction to that show. It was the $6 Million Man. And the point about the show was that after the astronaut crashed, we can rebuild him because we have the technology. We can rebuild the healthcare system finally because we have the technology. So I think technology is actually going to underlie and change the healthcare system. However, with COVID, it's happening much more rapidly. And we need to think about what we're going to be doing as technologists and as organization builders to complete that. So I'm going to tell you a little bit and just use a couple of slides from a talk that Indu Subbiah, my partner at Health 2.0, and I started to do about 3-4 years ago. And we call this flipping the stack. So what is the stack? The stack in healthcare, it's not quite what you think of as a tech stack. It's more about how we put together healthcare and healthcare delivery. So in the beginning, and the beginning was 10,000 years ago when the first witch doctors and shamans and eventually barbershop surgeons started getting together and started creating the healthcare system that we know it. We did in-person delivery of healthcare. And basically up until now, we did in-person delivery of healthcare. You wanted care delivery. Usually you needed a doctor or a healthcare professional and a patient to be together in the same place. Eventually that started getting very complex, right? We built hospitals, we built clinics, we did a whole bunch of stuff. We started laying services over those, things like nurse advice lines and telephone lines and a little bit of internet connectivity. And finally, especially very late in the US, rather earlier in some parts of Europe, like the Netherlands and Norway, but generally quite late, we overlaid technology to basically track what had gone on in those other areas. My argument is then that tech infrastructure is now so sophisticated and is now so widespread that it's actually going to flip the stack. What do I mean by that tech infrastructure? Well, obviously there are lots of parts to it. I'm not going to dive into this in too much detail, but there are at least 5 different parts to the tech infrastructure, and some might argue there are several more. So I've bundled things like video and sensors into this interface layer, but you could argue that there are several different pieces. Many of you are working in that data exchange layer and that transaction layer. The transaction layer is where orders and notes and sort of healthcare specific stuff that might be in Epic or Cerner happens. And then the data exchange and data analytics layers are ways that we're trying to take that information and do different things with it. And that's going to continue on. Obviously, data storage is changing with the growth of the cloud. But my argument is that now this tech platform, with all the technology, especially in the home, is so on the smartphone, wherever people are, is so pervasive that we can actually put that everywhere and start with the tech platform. Start with the ability to take patients and monitor them and have extremely close awareness of what's going on in their lives. Then if they need help, then we start adding services. Then we start adding virtual visits. Then we start adding tools to the home or tools to wherever they are. And eventually, that face-to-face care delivery becomes almost like a failure of the system. So this is really a very different way of thinking about how care has been delivered for many, many years. What about this system is very different compared to the sort of episodic intervention system that we have now? Well, it's always what I call the 4 M's. It's always measuring, it's always messaging, it's always monitoring, and it's always managing. So this is a constant thing when we think about patients, depending on what their level of acuity and how sick they are. We're all patients. We all need to be measured and monitored in some way. But obviously, depending how sick you are, and with diseases like COVID, that can be much, much more extreme. So about a couple of months ago, I started thinking about taking that platform, that idea of a technology platform, and flipping the stack and saying, well, how do you actually put this into practice? Because it's been a slow, long transition like many things in healthcare. And I started thinking about this mostly in the idea of this concept of, can you manage patients who are in quarantine and what kind of tools and equipment do they need? And I wrote this piece a few months ago, but I've just been working on a sort of broader vision of that, because it's not just patients in quarantine who need this new type of healthcare system. In fact, it's all patients, whether you have an acute illness, like the person on the left who's broken their arm, or whether you're requiring, interventions, whether continuous monitoring or IVs or whatever else. Every patient needs to be in a system where we understand what's going on with them. The problem is, been evidenced by the last 3 months in the US in particular, but also in most other countries, we have a massive system failure. And this isn't the tech type system failure. This is the organization, operation, and human system failure. Just here's a few of the things that have gone wrong that I just pulled a couple of days ago from the headlines. So number of them, things like that. So we sent a whole lot of patients into nursing homes, long-term care facilities, and they then spread the virus, fatal error. Reports about patients being sent home from the hospital, but not being monitored with COVID and then dying. The hospitals themselves completely overwhelmed, unable to isolate and manage patients. Too many hospitals dealing, in some areas with hospitals in some areas dealing with too many patients, while other hospitals in other regions, in fact, sometimes down the street, didn't have so many. And then, of course, we have two significant problems that we really haven't talked about, although in the US and worldwide we're starting to talk about one of them. One is the whole issue of the poor quality and the poor experience that we're getting for nursing homes. The article about non-profit nursing homes, for-profit nursing homes, is actually, if you look really hard, back in 2011. And then over here, it doesn't take a genius to know that we've had significant problems with minorities, particularly the Black and Hispanic community being much harder hit by COVID. And of course, we've had a number of other significant issues going on with, especially with the Black community, resulting in sort of the current protest that we see across the US. And it's now becoming a huge issue. And these two things are by definition connected. So we have this big problem. What do we need? This is the solution. We need a patient location independent care integration management organization. I used to call that a plicamo until somebody said to me that was pretty stupid. So what am I calling it now? We need a continuous clinic. We need a way that we can put together and build all the different pieces that are required to do monitoring and management wherever patients are. That means we've got to essentially blow up and think again about our current hospital-centric or even physician office clinic or clinic-centric model. And we've got to think about a way of really delivering care and managing the care of people wherever they are. Because that matters an awful lot depending on what kind of patient you are. You may be healthy, but need to connect in to a clinic or a service because you have something minor, and that's kind of where telehealth grew up. You may have chronic illness and need to be tracked maybe more regularly. You may need call center support. You may need a couple of connections a week with a coach. Or you may have an acute illness which could put you in the hospital, but you don't need to be there. In fact, most people with COVID don't need to be in the hospital, and many of the people in the hospital with COVID don't need to be in the hospital. So we need to figure out, how do you build this continuous clinic? So here's just a quick chart that I helped put together, which gives some idea of the types of things that are going on. And I'm just going to dive into this and show you this again in a minute. I'm going to dive into this because I'm going to ask this services organization, this continuous clinic, this sort of general contractor, if you will, to do a whole lot of stuff. First off, there has to be a lot of patient monitoring. And the good news is that the patient monitoring tools are now, with the advent of sensors, cheap sensors, are getting sufficiently cheap and sufficiently ubiquitous that you can actually put these in the home. So just around here, here we have connected thermometers. We have even a relatively cheap from Butterfly ultrasound device. And then this is the cardio device from LifeCore, excuse me, which is basically allowing us to get inside the home and do a lot more continuous monitoring. And obviously we have other tools like patient web apps or mobile apps, which are going to allow patients to do a lot of self-service. So the type of patient monitoring we're going to do is going to vary based on how sick the patient is. But there's a whole lot going on in this world. I didn't put continuous blood glucose meters on here, but something there will be part of it as well. But that's not enough. So that's the first thing we need is monitoring. The second thing we need is to get really good about delivering telehealth and virtual care as part of the care we're delivering. So I bring one example here. This was Bluestream, a relatively small telehealth company I've done some work with. And they went to the MedStar system, which is a big hospital system with 10 hospitals, 14 clinics, a bunch of other stuff in Washington, D.C. And they've been working on them for a while. And over the course of the early part of the COVID crisis, they increased the amount of telehealth they were doing by a factor of 500. So you've seen many of those stories. But what did Bluestream have that was really needed? They had essentially a provisioning engine. They had a workflow stream. They had intelligent queues. So the right people could be the patients could be sent to the right kind of specialist very quickly and easily, and they were able to train up the entire system on that very rapidly. That's the kind of thing we need to think about the workflow behind telehealth. So here's another idea. Here's actually another one from Bluestream. But we need behind the idea of where do people go, we need a lot of automated care processes, and these are starting to come. But this is one blueprint they did just for a 4-provider, 5-facility practice doing for nursing homes. So you can see the amount of activity and intelligence required in the system to figure out what do we do? How do we route people? This is something that healthcare has not done a great job of. We've basically said to people, you come to us and we will send professionals around to your room, or you'll sit in an exam room and wait. The idea is, how do we change the flow and use technology to take the needed resources to people? We have to think a lot about that. There's been a lot of thought about that over the years, but we need even more. And then, of course, technology isn't enough. We need to augment the care staff. Now, this might be a highly trained professional like this fella, sitting in front of a whole lot of different screens, understanding what's going on and doing the sort of virtual ICU. Or it might be, can we augment people who go out to the field? We do need to get human contact out to people in their homes, in nursing homes, wherever they happen to be. We've got to think a lot more about doing that. How do we bring that information together? Well, that's kind of where all of you on the line come in, right? We actually have this technology. We have a lot of companies doing a lot of the different things I talked about earlier. We have this interface layer. We have a lot of data analytics. These just, a few examples of the hundreds and hundreds of companies, thousands of companies who are building tools and solutions and storage and transactions, machines all up and down this. The management organization, the continuous clinic, is going to have to be able to have an open tech stack. Now, whether they're using their own care algorithms or whether they're using somebody else's, that has to be managed so that patients can get access to all the different tools they need, and these tools can talk to each other. There are still a ton of these things like, in fact, the Masimo Pulse Ox, which is probably the most advanced one on the market, is a good example, doesn't really play well with others. It's hard to take the data out of that. It doesn't really have an open API to be put in lots of other places. And you'll see a lot of that sort of that lack of data interoperability. I don't have to talk to you in this community about the lack of interoperability around the transaction layers between the Epics and the Cerners of the world. Yes, it's all getting better, but it clearly wasn't built that way. We need that as part of it. And that's probably the most important thing, because you've got so many different data streams coming in together. And that's not enough, because if you're going to start monitoring all these people, you need a very smart machine to start figuring out, using AI being the buzzword, how sick people are going to be, and particularly when they need to move from one level to another level, especially that involves then finally coming into a hospital or going to a clinic. So this is me, my little joke of a robot trying to get itself smarter by reading a book. And then that's not all. In the US, we need one more thing, which is to wrap all the nightmare of administration and billing that is in the US healthcare system in this organization and sort it out for people. So many people get these incredible bills. No one understands them. It's complete chaos. The Ron Cart will be on in a minute. I'm sure he's talked to you about this in the past. But I think this organization can do that as well. I think it can fix the billing and administration because essentially it's a general contractor. Any of you who've had a house built or when they open a big building or when a factory is built, there's some organization or a stadium, there's some organization which takes charge of this. The end user, the end purchaser doesn't have to figure out all the pieces that are going on behind the scenes. But in healthcare, we force that on the consumer and sometimes we force that on the primary care doc. And it's a complete mess. And we can do a lot better. And I don't see why this organization can't work to take that off people's hands. So that's the sort of summary of what I think we need. All of those slides where we need patients and caregivers to be access to the right kind of monitoring, the right kind of touch. We need them to get telehealth and communication from the right kind of staff. We need tools and processes and algorithms to do the right kind of care for them. We need to figure out when to alert tech-enabled augmented staff, when to get the staff who are looking at the machines to figure out when something's needed, when it's not. We need to get better ideas of how to manage payment, better ideas of how to manage to predict acuity. And of course, there are going to be times we need to do things like take oxygen or take people or take meals or take whatever to the home, to the hotel, to the nursing home, to the skilled nursing facility, even to other parts of the hospital, as you're going to see the hospital unbundle. But I think that's going to be the future. And there's a huge tech underpinning to that. So I think we can build this organization. The question is, what else do we need? Well, as I said earlier, I think we have the technology. Finally, we're getting there. It's not ready exactly yet, but there is all the technology we need in place. And we need two other things. First off, we need regulation. We're getting there in the US. We're starting to get there. We now have the 21st Century Cures Act, TEFCA. We have obviously the regulation and the consensus and community around FHIR. I mean, do a better job of enforcing. Honestly, the US has been pretty weak about this, and most other countries have been relatively weak about enforcing this. But we need to make it sure that that data is open, that data is flow, that data does flow. The other thing we need is to figure out how to pay people better and properly. Because right now, as I said at the start, we're paying people, we're paying organizations, we're paying doctors to do piecework. We're paying them fee for service. 90% of the US health system is fee for service. It is a historical accident. It makes no sense. It has to go away. Well, we're starting to do modest improvements, right? We're starting to do things like pay for remote patient monitoring and chronic care management, small sort of adds to the overlays to the fee for service system. We're starting now to actually pay, we're now paying for telehealth properly. What's happening next is more important. What do we go from here? How do we change the way we think about the system? Do we go for what some people are arguing like George Halverson, Medicare Advantage for all, where we put everybody into the Medicare Advantage system and essentially pay fixed capitated payments to the networks of doctors and hospitals, and that will enable these types of care management organizations to flourish, I think. Or do we just go for a straight universal insurance system, much more as common in Europe or Japan, where we're actually directly paying sort of salaried staff and putting them into a process which allows them to do different things. I think there is huge need to change that, and we're going to see big changes in the system because we've just realized that what we're doing now can't go on. So if you have those two things, if you have money and regulation bolstering, I think you'll see the growth of this continuous clinic. And then the question is, in the US particularly, but elsewhere, who's going to provide these continuous clinics? Because this is going to be a huge change, and these will be the people that all of you techie folks are going to be working for. So you start off with, on the top left, might this be the tech community? Might this be a Google? might be an Amazon, an Apple. They've all got different parts of the panoply, right? Whether it's monitoring, whether it's the cloud services, whether it's the tech-enabled services, whether it's the delivery to your home, like an Amazon. I think you're going to see a lot more of that, a lot more of a play from those tech giants in this space. And even already, Amazon has got a clinic and a virtual clinic that's running for its own staff. I think you'll see that grow. Of course, you've got the main incumbents, the top right, the currently big medical centers, the ones who've got the multi-billion-dollar endowments. I was reading just now an article about a small brewery in Washington, D.C., which is making beer to pay for PPE for the Innovator healthcare system. The article points out the Innovator healthcare system is now getting a brewery to give it money, and raising money, funds that way for its PPE. It has $4 billion in its endowment. Doesn't seem exactly right, but those well-endowed systems may well end up being the people who deliver this if they can change. Of course, you've got some huge companies in healthcare. The pharmacy chain CVS, which has bought itself an insurance plan, Aetna, an Optum, United, the biggest healthcare corporation there is out there, which is rapidly buying other pieces, including physicians. They may well be the players who put this into place. And then I wouldn't leave out the people who've traditionally been the most important in healthcare, which is the clinicians and physicians themselves. You're seeing organizations like LDATE help independent physicians manage capitation, manage risk, and they've usually been very smart about. And there's a lot of clinics which are being venture funded. They may end up being the ones that do this as well. People like IORA or Village Care MD. But as far as I can tell, you've got a lot of innovation in that space, which again looks something like could start putting together this continuous clinic I've been talking about. But I think it's our job as healthcare technologists, and I'm not really one, but I'm a person who observes healthcare technologies, to make sure that we're ready in place for this new world when it comes. And with that, I will thank you for your time. Thank you for your attention. It's totally weird giving a presentation when I can only see the screen. I have no idea there are hundreds of people out there. I hope you enjoyed this. I will take questions in the Q&A. There are a couple here, and I'll try and answer them in the Q&A. And here's my information. Please feel free to get in touch with me. I do a jokey show about health technology called Health in 2.0 that's on the healthcare blog every week with Jess DeMassa. I tweet a lot at Bolty Boy, not just about healthcare. I tweet a fair amount about soccer and politics and other fun stuff. And that's my email. So look forward to touching base with you. I want to thank Rin and Ewout, Charles at HL7, and all the rest of the folks who put this together for a great show. Let me know if I can help in any way. And now it's my great pleasure to introduce the next character, and he certainly is a character. The next person coming up is Dave the Broncart. Dave is known as e-patient Dave since he had a cancer diagnosis and became the crazy guy who Googled his ass off and then actually chewed out his both Google and Beth Israel Deaconess back in 2009. He's been a star of the patient movement. He was one of the founders of the Society of Integrative Medicine, and he's a lot of fun. So Dave, take it away.
Is this thing on?
This thing is on. You're all on.
Great. All right. Got a little bit of Boston skyline in the background here. So for those who are not familiar with the history, Matthew, as self-effacing as he is, and as full of crap as he is, actually knows something about what's likely to happen in the foreseeable future. He was one of the earliest people back in 2008 who encouraged me to start doing this evangelizing stuff, and he's given me advice. I'm really interested in what he says about if this system, one of the things in my cancer diagnosis when I was almost dying, I have a philosophical sister, and she said there was a Japanese saying, a farmer who said, "My barn having burned to the ground, I can more clearly see the moon." And as we think about what a rebuilt US healthcare system might be like, I want you to be thinking about what if all of a sudden we did it. Wait, I have to do screen share before I can show you my slides. You'd think I'd know how to use Zoom by now. There we go. All right. Come on. Project. Thank you, thank you. So what if we do it with the patient's perspective and wants built in, baked into the fiber, the fabric of the system. I stepped out on my deck here in New Hampshire and took this photo today. I'm wearing the MITRE Corp shirt, Own Your Health Data. And I want every one of you to be thinking that way. I'm going to give you a very brief introduction before today's presentation. You just recap briefly Ross Martin's song, Give Me My Damn Data. And the damn is data about me, all right? I said yesterday at the start of this track, we are at the very beginning stages here, similar to when Lewis and Clark explored the western part of North America. We have just arrived at one side of a river and we can see the other side. And we are just beginning to do the tedious poling the rafts across the river work. Patients have begun showing up at DevDays. A couple of years ago, Michael Morris, who has since died, talked about how he was using FHIR to pull together his data from multiple hospitals to give his doctors a dashboard that they don't have, all right? And in Amsterdam last fall, Christina Sheridan talked about how with her daughter's horrible case of Lyme disease, they took all these printouts of CCDs that they'd gotten from her 15 doctors, 30 diagnoses, and typed them into Excel and created their own dashboard, which ultimately led to the girl's cure. The vision of that talk last fall was, what if we could do what Christina had to do manually and put it through automated FHIR pipes, the way Mike Morris did. And 1 year ago in Seattle this week, Dana Lewis, the famous open APS automated pancreas inventor, spoke. You know, at a different talk, I heard Dana talk about an anecdote, and this is thinking about rebuilding the system from the point of view of the person who has the need. She was confronted by a doctor at some event who said that all this stuff was crap, that patients couldn't possibly be doing anything useful. And what she said was, you're wrong and we don't need you anymore. Now that's not to say nobody needs doctors, but these patients have become autonomous and we want to enable that. And last fall in Amsterdam, John Keyes was the winner of the first Patient Innovator track, the competition. He, as a developer, had created an app for his own use to track the numbers for his blood cancer. The future that we have in mind is to go from fording that river laboriously to this information superhighway where people who want to get somewhere in the future of their health and their care can do so unobstructed by obstacles. Your judging panel for these 4 presentations, we had one yesterday, one today, and 2 tomorrow. Virginia Lorenzi, Graham Grieve, and Ross Martin. I'm the leader of the track. And this is audience participation for the first time, DevDays first, because in addition to the judges with the official criteria, we're doing a People's Choice Award. Wednesday night and Thursday, you will get to vote for whichever one you liked with no rules, strictly. So you'll be getting a poll email Wednesday night and you'll need to vote by Thursday noon so we can give the awards Thursday afternoon. One last item before we get moving. You can now watch Morgan Gleason's video from yesterday. Anyone that you missed for the voting will appear in their agenda slot in the Whova app. So that'll be terrific and really help things out. So without further ado, ladies and gentlemen, I bring you our first African entrant in the Patient Innovator track, Olivier Karasira from Rwanda. And you'll see in his video what they are doing. They are starting from no existing EMR infrastructure. People's medical records are on paper if they're anywhere. And so they are taking this directly into FHIR and SNOMED CT in Africa. So now if we can switch over to Olivier.
Hello, this is Olivier Karasira. Today, we will be turning paper medical records into FHIR and SNOMED city encoded records in Africa. I recently used FHIR and SNOMED city to achieve something that neither I nor medical professionals and administrators I have spoken to know of having happened anywhere else in my home country of Rwanda, nor in the next door Burundi. Using a platform called the Sovereignty Network, I have shown that whether it be Uganda, Rwanda, or Burundi, we can bring together all types of data from different sources such as labs, electronic health records, and clinics, usually recorded on paper in Africa, and turn them into a global, interoperable FHIR and SNOMED city health record, held under the patient's control or parents' control in the case of school children. I hope you enjoy the next few minutes I filmed on the ground to give you a taste of what we have actually filmed on location in Rwanda and Burundi. The journey started in Rwanda in 2015 when my team thought about an holistic approach to support children and adolescents' well-being. With that in mind, we created an educational technology platform able to generate real-time data for student behavior, cognitive load, and health analytics to help improving student performance and health during their educational journey. Health is an essential for students, and lack of it affects their ability to learn. For the past few years, we worked on pilots, heavily on infrastructure and research. For example, 60 laptops, 60 tablets, 96 mobile phone and internet connection to deliver the platform. 2 schools in Rwanda and 1 in Uganda tracked student behavior, cognition, and health, including diseases, diagnosis, allergy, disability, etc., at school level. But we always lacked the ability to codify and share the health data efficiently, track it outside of school, and ultimately scale out through Africa, which is our dream. I was personally able to perform the key steps of first sourcing and then transcribing the paper data, written in a bad handwriting and most of it in French, of 10 patients by working with them myself, and that enables sovereignty data converters to convert blood test data, doctor's notes, signs and treatment, medications, diagnosis, ECG readings into a FHIR and SNOMED city encoded record. These patients now own and control their own health records, and one of them in Burundi is now also starting to help other patients get their data, following in my footsteps. Further, we will be starting a collaboration between parents and schools to keep student health files updated and portable in the cloud with the best-in-class technology, such as FHIR and SNOMED city. This is so much better than scraps of paper that get lost and destroyed.
I'm currently in my 5th year in medical studies in Burundi. I worked with Olivier Karasira as my data champion. And with basic training, we were able to clean and collate my original paper data, which were in French and in a bad handwriting. We prepared files for Sovereignty's data converters Today, I have portable, electronic, and shareable health data record under my ownership and control. I'm excited to do the same for my friends and family because too much health data sits on paper files and notes, scattered in people's homes, and sitting inaccessibly in doctors' offices and hospitals.
Notre pays est en train d'avancer à grandes échelles dans plusieurs domaines, surtout ceux liés à la technologie. Il va de soi que l'amélioration de notre système de recueil des données sanitaires va influer positivement sur la prise en charge des malades. L'application de ce système va aider tout un chacun, malade, prestataires, décideurs, à mieux prendre en charge les malades par la voie de la prévention, le traitement approprié et le suivi des malades.
Now, with the tools we have, we are only limited by the willpower of the people, and we can extend our vision to include all people in Africa. One by one, we can teach everyone to either get the data themselves or be a data champion like I have become, and help people to get it, convert it into an interoperable FHIR and SNOMED city record. This data is very much needed in Africa so that each person can take control of their health data and through that manage health proactively with great understanding and have it follow each of us wherever we may be and share it with others when we want to and need to. We desperately need better quality and more timely health data in Africa so that we can capture and measure outcomes. The Ministry of Education and Health in Rwanda have been putting a lot of effort supporting all boarding school students age 6-18 with milk each day and mosquito nets. Indeed, a school near where I live in Kigali has a student population of just 1,438, and yet the school clinic receives 5,850 visits per year, an average of 4 visits a student. This is the kind of reality often faced in Africa. Sovereignty patient records will capture and make measurable what the issues are and what helps. Additionally, sovereignty interoperable records will potentially be accessed by global researchers much more easily. Right now, most people just have scraps of paper at best. Our journey focus is to support children and adolescents' well-being based on timely and accurate data, wherever, whenever it's needed. I hope you may be able to help me. Thank you for your time and attention.
So, Olivier, it's good to see you again. We're doing one for the audience. We're doing one question from the judges for each of the participants, and this is a two-part question, two related parts. They ask, what are you going to do with this data now that it's in FHIR and SNOMED CT, our understanding is that electronic health records are not widespread in Africa. So what are you going to do with it? And once you do that, how will you handle unique identification to make sure that you don't end up mixing up records and control access to it?
Thank you very much, Olivier from Middle East Africa. First of all, as I told you, as you heard in the video, we are doing this at the school level. We are helping parents to have the medical files of their children on their mobile phone. The second idea, we are building data, how can I put it? We are building a data licensing business for people in Africa. And by that, we can find a way how to reward parents that are champions, that are partners for sharing data to research or survey. So the part of how we manage the security, we are having a partnership with Sovereignty Network. They have a FHIR converter. They are handling the expertise of sharing those information on parents' mobile phones and how we deal with research and survey sharing information. That's the way we do it.
Good. Okay, so that's through Sovereignty Network. All right, great. Thank you very much. And I guess we will turn it back over to headquarters to continue.
Thank you very much.
All righty. Well, thanks for the pitch, and thanks all the speakers for this interesting opening. I promised you would be running early. How could I have thought so with two characters like Matthew and Dave? But it's 1 minute to the hour, so I'll let you go and choose your next session, and see you later or tomorrow. Bye-bye.